talk about safety and feasibility of home care neuromodulation and monitoring wearable device for treatment of atrial fibrillation.
Hi, I'm Avi Sabag from the Sheba Medical Center in Israel, and I'm here to share with you the result of our study titled Safety and Feasibility of Home Care Neuromodulation and Monitoring Wearable Device for Treatment of Atrial Fibrillation. I have nothing to disclose. As we all know, atrial fibrillation is the most common sustained arrhythmia, and its prevalence is expected to keep on increasing. Our treatment options have improved tremendously over the last years, resulting in improved control of the arrhythmia and even improved outcomes in selected patients, but treatment is still imperfect. The rates of recurrence after a cardioversion are high without intervention, with about 30% at 4 weeks and 80% at 1 year. The autonomic nervous system is heavily involved in the initiation and perpetuation of atrial fibrillation. Both the sympathetic and parasympathetic, intrinsic and extrinsic components are involved, and as a result, these components have been targeted for treatment. Attempts at renal denervation, ablation of ganglionic plexi, stimulation of the vagus nerve, either directly or through the tragus, have all showed some promise. The median nerve is another interesting target for intervention, as it receives sympathetic innervation from the stellate ganglia. Preclinical data has shown that stimulation of the median nerve can result in reduction of sympathetic firing, a reduction in atrial and ventricular arrhythmia, and reduction in the inflammatory markers associated with atrial fibrillation. Our study was designed to assess the technical feasibility and safety of the CardiaCare wearable neuromodulation system. The system comprises of 3 components: the wristband itself, capable of performing a single lead ECG monitoring and delivering the neuromodulation, an application based on a smartphone, and a cloud data storage system. Our primary objectives were to assess the technical feasibility of the CardiaCare system over an 8-week intervention period, and the safety of the system in symptomatic atrial fibrillation patients. Our secondary objective included a reduction in PAC burden, an effect on the rates of atrial fibrillation recurrence, and compliance with the system. And lastly, to assess the performance of the entire system, including the cloud software. Specifically, our primary outcome measures were the number of ECG recordings successfully performed by the patient, then sent, received, and stored by the system, the number of neuromodulation treatment successfully administered by the patients, with parallel recording of those events, and those recordings should be received and stored by the system. This was a prospective single-arm proof-of-concept study over an 8-week follow-up period. Our patients were recruited at the Sheba Medical Center Emergency Department. We had 3 in-hospital visits. Patients had a Holter recording done at the entrance of the study and at the last week, and had 2 scheduled phone visits throughout the study. The use of the CardiaCare system was added to gold standard therapy. First intervention was done under direct supervision of a physician in hospital. Patients were required to record a 30-second ECG 3 times a day throughout the study, and required to perform 2 neuromodulation treatments a week throughout the study. This intervention started with a 2-minute recording of an ECG through their wristband, delivery of the neuromodulation, and performing a follow-up ECG recording. Inclusion criteria. Patients had to be 18 years or older with symptomatic atrial fibrillation, with a current event lasting less than 48 hours. All patients were required to have a cardioversion with conversion to sinus rhythm and provide an informed consent. We excluded patients that were hemodynamically unstable, had an acute MI, had signs of pre-excitation, history of significant bradycardia, or heart failure. Our preliminary results: we have recruited a total of 11 patients, 7 men, with a median age of 66. One patient, however, dropped out of the study before starting the protocol, and the remaining 10 completed the entire study. We had a very high rate of compliance with the study protocol. We had 95% compliance with performing the scheduled ECG recordings and 97% compliance with performing the scheduled neuromodulation treatment intervention. Our safety results: we had no adverse events during the initial supervised treatments and no serious adverse events throughout the entire study. We had no unscheduled ED visits. One patient did report some minimal itching during neuromodulation treatment. Another reported some tiredness. A third patient did experience some symptomatic bradycardia related to her treatment. This was resolved with lowering her beta blocker dosage. One patient underwent an AF ablation at 6 weeks. We were able to get some initial data on the efficacy of the treatment with observation of a change in the PAC burden. We had 7 instances where we had an ECG recording capturing multiple PACs before neuromodulation treatment, and we're able to compare it to the post-treatment ECG, and in all of those instances we've observed a decrease in the PAC burden. You can see that the median rate of PAC was significantly reduced following the treatment. We had a total rate of 20% of atrial fibrillation recurrence over the 8-week period, and this compares nicely to a 38% observed in historical controls. Here you can see examples of the single lead ECG captured by the system, and you can see multiple PACs before treatment. On the left and on the right, you can see that following the neuromodulation, we have just clean sinus rhythm. Conclusion: we've demonstrated that the system is very safe. There is a high rate of compliance with treatment and monitoring, and we've seen some initial hints of its effect with an acute reduction in the PAC burden. Also, the rates of AF recurrence with the use of the system are relatively low. Our next step will be the BEAT AF study. This will be a sham-controlled trial over a 28-week period of follow-up. Thank you for your attention.
Thank you. And next to our sixth presentation for the